Good morning, everyone. I hope everyone's doing well. I know things are starting to get a little heated again with the COVID, so please know your thoughts and prayers are with us all. And as always, if there's anything anyone can do, please reach out. Can you move to the agenda, please, Claudia? As you can see, we have some coding topics today. Ann Hutchinson from the Health Home was gracious enough to present what they're working on with the social determinants of health coding. And then our ever popular presenter, Brenda, will be talking about coding and giving us all helpful hints. We have a few brief updates about the PCMH. If you could go to the next slide, Claudia. Wondering how many people have submitted. Are there those that have not submitted that are on track to submit by the 30th? Again, if you were due between April of this year and the current date, you were granted an extension till the 30th of November. Is anyone needing some supports? I appreciate some of you have reached out to us to help with some of the logistics. We do know QPAS still has their issues. And I'm going to turn it over to Jessica to talk about a few things she has noted. She's been in there quite a bit over the last couple of weeks. So Jessica, if you want to give us a little bit of your insight between QPAS and then the Zoom accounts, that would be great.
Absolutely. All right. So good morning, everybody. I won't take up too much time today, but I do want to speak to a couple of those things that Luann had mentioned. So, first of all, as a heads up to folks who haven't yet clicked the submit button this year, in working with practices that are submitting their second year of reporting on the New York State criteria, we've come across some glitches in QPAS to be aware of, and they seem to be occurring globally. So, most notably, a number of criteria inside QPAS appears to be locked and marked as met even before the practice has submitted. The most common criteria affected by this seems to be CC21, QI19, ARKM2, and ARCM2. So if you're working in QPAS and you notice that these criteria are locked and marked as met, they should not be. Those are all criteria that you should be submitting something to NCQA on for, whether it be, your value-based agreement for this year, evidence that you're still connected to an HIE, some data regarding your depression screening, or information about care management. So those should not be locked for you. And if they are, NCQA's guidance is to reach out to your representative to have them unlocked so that you can submit your data. The other one that doesn't apply to everybody is CM09. So if you last year took the attestation to say that your care plan is not yet interoperable or integrated, but you plan to show evidence next year, this is the year you would have to show evidence. And for those folks, QPAS just has it marked as met. So you have to be aware of what you did last year. And if you need to show that evidence this year, you'll need to reach out to NCQA. Also, we did mention last month that NCQA has transitioned from Skype to Zoom. Since then, I have been able to participate in the check-in using this new platform, and there is a key difference, and that is that now you are required to actually create your own Zoom account using the email address you use in QPAS. So this is different than meetings you may have attended in the past where all you need is the sign-in information and a passcode to get into the meeting. So they do this as an extra layer of security to make sure that folks joining the meeting have been authenticated. But if you're not aware of this step before your check-in, it can take some time to set up an account. But you'll only need to go through this process with Zoom if you have a new site that's going through the transforming process or if you're selected for audit. So I did want to throw that out there. I know most of you guys are in annual reporting, but if you ever did take on a new site, or if you are selected for audit, you will have to go through this virtual process with NCQA, and they do at this point require you to have just a basic free Zoom account. So that's all I have for today, but if there are any questions, feel free to reach out.
Thank you, Jessica. Anyone on the line with any questions or comments or insights?
So Jessica, do I understand, if it's your first year doing it in QPAS, you probably won't have these issues?
You shouldn't. So if you have not yet submitted anything for New York State criteria, and this is your first time going through that process, I have not noticed the issue with practices that are doing this. I've only noticed it with practices that are in their second year of submitting under the New York State criteria. But at any point, if you're working in QPAS and you see something that's marked as met and you've never submitted it before, and it stands out to you as, geez, why is this marked as met? I would reach out to your rep and say, what's going on? Does this need to be on? Because I've never submitted evidence for this before.
So probably wise to not wait until the 30th to submit everything.
Yeah.
Probably.
Okay.
I know some people have actually even called and were able to get the locked items released. So they are aware of it and are turning around the request fairly rapidly. So, if you have a few minutes, give a call and it can, potentially be done literally within minutes.
Thanks, Luann.
Okay, without any further ado, can we go to the next slide? I'm going to turn this over to Ann Hutchinson.
Morning, everyone. Can you hear me okay?
Yes.
Very good. So good morning, Ann Hutchison. I'm the director of AHI's Health Home Program. Luann had asked me to come in and talk to you all this morning and give a little update on what health homes are doing as it relates to social determinants of health. So before I do that, can you go to the next slide, please, Claudia? I am just going to get, oh, you went a little too fast. Can you go back, please? I am just going to give you a brief overview of the Health Home Program. I know that folks from my team and presented previously, but I thought for those members of the group who are new, I would just do a brief overview of who we serve and kind of how we go about our work. So the Health Home Program is a New York State initiative. There are roughly, I'm going to say 16 lead health homes, don't quote me on that, across the state of New York. We serve Medicaid eligible members who have chronic conditions or behavioral health issues and also social problems. So these are your highest risk, highest need members that we're targeting. So think a lot about high utilizers, frequent ED visits, complex medical conditions, mental health conditions, substance use disorders, incarceration. These are the folks that we're going after. Next slide, please. As I said previously, this is a statewide initiative. There are many health homes across the state of New York. AHI is one. Within as a lead health home, we oversee a network of care management agencies. The goal of the program was to bring in care management agencies that bring with them a kind of diversity in what they do as far as being clinical providers, behavioral health providers, and social services providers in the spirit of breaking down silos between those providers in service delivery. Next slide, please. And so I just wanted to give you this slide as a reference. These are all of the care management agencies that are in our network. So any one of these organizations provide health home care management services. We serve 8 counties, so we are essentially Saratoga County all the way up to the Canadian border and then over to St. Lawrence County. So we have a pretty pretty broad territory. Next slide, please. So just a little, I know it's probably somewhat obvious, but just a little overview of the care coordination process. Our objective with every member is to assess. So we need to know what the problems are, what their needs are, to assure that we document that in a shared electronic health record, that we are referring members to the services that they need, and then that ultimately we close that loop. So just for clarity's sake, the role of health home care management is not to provide direct services, and I mean that in the spirit of like a clinical service. It is more so very much about connecting members. So it's the actual coordination piece. It's not actually being the service provider. Next slide, please. So
go. Sorry, Bingo, go.
Oh, is there a question? So related to the assessment, for every member that's enrolled in the health home program, a comprehensive assessment is completed upon intake into the program, and then at minimum on an annual basis. The objective of the assessment is that we're identifying any clinical, behavioral, or social health problems. The purpose of me speaking today is to talk a little bit about, or more specifically about social determinants of health. So that's clearly part of our comprehensive assessment and within scope of a health home care manager to address. What is exciting about where health homes are at this point is that as of very recently, within the past couple of months, we have implemented a statewide standardized social determinant screening. So previously, health homes have been in play since about 2013, and we have always addressed social determinants of health. We have always assessed members and helped them meet those social determinant needs. But what is exciting is that we now have a standardized tool that's being used across every single health home in the state of New York. So that's kind of the exciting piece of all of this. The tool that health homes have implemented is a subset of the CMS tool that's used. So this is a kind of a federally backed tool, and it got some use case with an initiative through the Centers for Innovation with CMS. So it's a 10 questions, not too painful for patients or members. And as I stated, it's a subset of the CMS tool. Next slide, please. So the tool essentially covers 5 domains. So all of the questions kind of go back to these 5 categories. Does the patient member have housing instability, food insecurity, transportation problems, need help with utilities, or are there safety issues within the home? Next slide, please. So upon completing the social determinant screening, any problem, whether it's a social problem, a clinical problem, or a behavioral health problem, is documented within our electronic health record, which is NetSmart Care Manager. Every organization that is a health home downstream provider uses this tool, uses the platform, and we all document in the same way, in a standardized way, across all agencies. Within our system, we have ICD-10 and SNOMED codes available. And those are the codes that we're using and have been using since 2013 to document not only social determinants, but other diagnoses of problems. Next slide, please. So one of the challenges we found with documenting, or we continue to find, I shouldn't say found, but we continue to find, is that when problems are identified and the ICD-10 and SNOMED codes are being used, there is literally a gazillion, okay, maybe not a gazillion, but there's a lot of codes for a care manager to choose from. And we really wanted to pinpoint and be able to report on what the social determinant issues were. So we kind of canvassed the Z codes and the SNOMED codes and came up with associated social determinant codes that best related to the questions being posed on the comprehensive assessment. So in other words, we are telling our network, if a patient member answers, let's use housing instability as an example. If they answer yes, and anything is other than perfect, that we want you to assign this particular code. So that kind of alleviates the need for the care manager to go in and canvass there's just so many different options, and we would never really, it would be very difficult from a reporting perspective to get and isolate the actual problem and then the outcome of that. So in other words, how many members started the health home program with a housing issue, and what was our intervention, and what is the status? Was it resolved? And then, I mean, what's really exciting is you can then look at the value add of that. What was the member's total cost of care before they had that social determinant intervention, and then what is it now? So what is the impact of that health home intervention? Any questions so far? I'm kind of a fast talker. I'll apologize, and I'm especially fast early in the morning. So let me just pause for 30 seconds and see if there's any questions so far. All right, very good. Next slide, please. So as I had mentioned earlier, the goal of the care manager is to refer the member or the patient to a service provider to address the need. So whether it's whatever the need may be that's identified in the assessment, that is referred to a provider who can actually provide the service. As I said, all of everything is documented in the electronic health record. The referral is made within the record as well. Service providers are inventoried within our electronic health record, so a care manager simply can click on the service provider or add a new service provider to link that provider with that particular problem or issue. Next slide, please. So, kind of back to our objective and what we're hoping to accomplish is that throughout the process that the needs that are identified are addressed, and that through the care coordination process, we're closing the loop on those needed services. We, at minimum, are in contact with our members on a monthly basis. And the goal always is, if a member, say, all the loops are closed, and just to be perfectly honest, the population that we deal with are, they're very high risk, they're high need. And I would say a lot of the time, all loops are never closed, right? There's always, there's certainly issues that seem to linger, but the goal being that when a member discharges, there's a good plan in place, and they're able to essentially address whatever additional needs they have by using community resources. So that is all I have for today. Any questions or comments related to social determinant screening using Z codes or SNOMED codes? All right.
Right.
All I have. Thanks everybody for your attention and your time.
Thank you, Ann. That was really helpful and very informative. I appreciate your time. The next agenda item is, again, talking about some additional coding stuff, and Brenda's going to lead us through some insights we should be aware of. So I'll turn it over to Brenda.
Thanks, Luann. Thanks, Anne. That was, you know, a really great presentation. And certainly, I think from all standpoints, I think one of the things that you brought up was just the ability with all of the codes that are out there is really, you know, what is it that we use? And certainly across payers, I know for Health Home, you're certainly looking at the Medicaid Fidelis population. But, you know, it becomes very difficult, you know, to how do we hone in and what is valuable or not valuable. Claudia, if you could go to the next slide, that'd be great. Certainly the ACO has taken the focus this year. We have been focusing on risk coding and the different opportunities that are available, you know, to our providers. One of our data analysts developed, many of you on the call have seen it, or certainly in the near future will be as we, you know, roll it out further to our PEDS practices and some of our behavioral health partners. But, you know, the risk coding is really our opportunity to really show our payers how complex our patients are and how important that is for us to be able to certainly, you know, in our value-based payment contracts to really realize any shared savings. And it's really based on this risk coding of our patient. Another piece that comes out of the risk coding, especially if you've seen the risk workbook, is really being able to identify gaps in care. And I know many of you participate in incentive programs with our commercial payers, and you know, certainly they focus on, you know, a lot of the gaps in care. So, you know, just a diabetic, if we know they're diabetic and they're complex, we know that we have to make sure, you know, the A1Cs, the, you know, foot exams, all of those things need to be done. So really trying to combine an opportunity to not only look at risk coding, but also to close gaps in care while we're focusing on this patient. So through the coding, we're able to, you know, show the severity of illness, you know, family histories, their past medical histories. And as Anne pointed out, we also have the opportunity to also include the social determinants of health, which certainly go in and look, you know, certainly increase the complexity of that individual as we're trying to perform care coordination. In the ACO, or, you know, any payer, especially in the Medicare world, you know, annually we have to, when we get the patient in, recode any of their chronic conditions as well as any new conditions, and then also close out, you know, some diagnoses codes that no longer exist. And those are the things that we really need to focus on yearly. It's an opportunity to be able, again, to recapture codes that we may have missed in years before. So, you know, it's something that's an ongoing process for all of us. Next slide, Claudia. If you can try, there we go. So one of the things, you know, the focus today was on the social determinants of health and also the Z codes. And the Z codes actually offers us the opportunity, they not only represent social determinants of health, but it really are different things that influence our health. You know, Z codes represent contact and exposures that may happen at work, a status of an illness, a personal history of. Certainly, as we move forward, a lot of you who are doing screenings in the office, that's how you utilize the Z codes for capturing depression screening, any other screenings that may be done in your office, as well as I've listed out the social determinants of health Z codes. Next slide, please. So what I've done, and I think it sometimes when we're talking about risk coding, again, the higher the risk of an individual, the higher, you know, our payers are able to say, you know, assess how you know, how much money needs to be allotted for the care of this person. So a lot of the you know, when you're coding an individual, we have to think about how complex is this individual, And, certainly if we don't show the true picture of the individual in the coding, the money that's allotted for that individual is not, I'm making it very simple because it's much more complex than that. But certainly the cost of care is going to be less if we're not showing the true picture. So in this example, we have a 65-year-old who's in for his yearly exam. He has a history of diabetes, retinopathy, and hyperlipidemia. And you can see his vitals listed, as well as, showing he has a BMI of 43.9. His A1C is 6.5. And, socially, he just retired. And, he is having difficulties, making that transition into retirement. Next slide. So you can see in scenario 1, this is something you can see that they coded him as a diabetic as uncomplicated. And you can see that, there's a risk score or a weight that's associated with that. And then you can see that they diagnosed with obesity. They did not tie the retinopathy in with diabetes, and you can see that there are no weights to any of these diagnoses codes that were added. So if you go to case, scenario 2, you can see the different weights that are associated, as the diagnosis codes are utilized, showing the specificity. So, here we are, they recoded it as diabetes type 2 with unspecified retinopathy. So you can see, the change in the weight, and then going down and coding the morbid obesity and the weight that carries. We know as a diabetic, those are things that, the importance of coding the morbid obesity, as you can see, certainly influences the outcome. And when we go on, adding that Z code, I think the big thing here is just showing, it gives you a more complete picture of what was seen at that visit. It may not influence the risk score of the individual, but we know that, especially I think for all of us who are on the phone with COVID, we were looking at who are some of our individuals who could be more at risk during this time if they're isolated. And certainly some of these could be a trigger for us. Next slide, please, Claudia. So in this case, we have another diabetic. I pick on the diabetes all the time, with polyneuropathy. She expresses how expensive her medications are and the difficulty meeting monthly expenses. She has a history of great toe amputation 5 years ago, personal history of uterine cancer with complete hysterectomy. She continues to smoke a half a pack per day, and she has a history of depression. She was screened for a PHQ-9 and the score was 12. Complaints of increased fatigue, lacking desire to participate in family events and activities since the loss of her sister. Next slide, please. So again, same thing here. The first scenario, we have, again, diabetes uncomplicated, along with the nicotine dependence and a history or a major depressive disorder, recurrent, unspecified. So you can see that, these different, the different diagnosis codes that are utilized in PICS certainly are, to Ann's point previously, if you're not utilizing the right codes to show the complexity of the individual, it's not a true representation of what there may be for risk. Even though our Z codes may not carry any risk, it certainly shows the complexity. So in scenario 2, once again, when you start looking at diabetes coding to the specificity, when there's any amputations, certainly this is something that we've noticed in the ACO. A lot of times an amputation of a toe, those things sometimes are forgotten from year to year. So certainly important to look at the opportunities. You can see how that does increase the risk score of the individual, as well as recoding the major depressive disorder. And then we go on looking at, disappearance and death of a family member, their personal history of uterine cancer, as well as a total hysterectomy. And then again, the low income. Certainly this is pretty, I was just utilizing how you can present the picture depending upon, certainly it takes a lot of time. There's more time that needs to be done when we're looking at this. But when I think of our work with our behavioral health partners, certainly with Health Home, these are different opportunities that are out there to show that there are different billing, people who are participating in the care of this individual, where these codes could be certainly picked up by other providers that are within our network to help us certainly represent the complexity of these individuals. One thing that I do know, certainly for us who are out there trying to close gaps in care right now at this time of year, we all know it's kind of a crazy time for all of us. As listed here, the total hysterectomy is a place where if this is recoded every year, and especially in our younger population who may change jobs frequently, do change insurances, that code, that total hysterectomy, does not follow that individual from payer to payer. So that's why these codes are really important, because if that Z code if that code is utilized, that will remove that individual from your gap list. So the importance of doing that, certainly decreases the amount of work on your end that you have to do if that is recaptured on a regular basis. Next slide, please. So our last case is a 45-year-old male in for annual wellness. He has hypertension, monitors his blood pressure several times a week, and is taking his medication appropriately. He has a history of alcoholism, reports he remains abstinent, continues counseling to address issues regarding past childhood abuse, which led to removal from parents' home because of alcohol and drug addiction of parents. Next slide, please. Again, you can see that for this individual, the only thing, if hypertension and it's well managed and it's not associated with any, chronic kidney disease or anything of that nature, there is no weight score for this individual. If we go to scenario 2, again, alcoholism and remission, I think these are some of the codes that we tend to miss. We miss the opportunity to be able to show the complexity of the patients that we care for. And you can see how just, coding the alcoholism and remission, does again increase not only the risk code, but also when we look at COVID, this is another time where this individual, this may have been somebody that could have been pulled as a high risk if they became isolated. Would this be somebody who we would identify that may need an extra outreach? Again, it said that he was continuing counseling, but showing our behavioral health partners the ability to use the Z codes to certainly represent the complexity and the fact that somebody is still remaining in mission with the history, the appropriate supports are in place to help, manage the individual. The next slide, certainly if anybody has any questions or feedback that they'd like to present or ask, that would be great. I'm just gonna, certainly just one thing. I think it's just really important. I think as we move forward, the importance of the collaboration, between the primary care and the behavioral health world, our partners. I think, certainly those are things that we can capitalize on and really, work together to certainly show the complexity of the patients that we're working with and ensuring that the appropriate, certainly resources and or supports are in place for them. Thank you, everybody. Thanks, Luann.
Thank you. That was really great information. And again, I think you can see the difference of just putting in some of those other codes we may not think about on a daily basis can really make a difference in your patient population. Does anyone have any comments or feedback, or have you been looking at some of your coding opportunities? Anything anyone would like to share around that? We are all awfully quiet this morning. Is it too early? Okay, well, I'll go ahead and move on. The December topics that we're looking to do is around the 2021 PCMH updates. We're working on updating that tracker grid that we have pushed out before to make sure it includes all the updates. There was not a lot, but there are some. And the other piece we're trying to incorporate as we continue to get feedback from people that attempt to use it is truly understanding what you really need to submit for the annual recognition versus what you're just having to make sure internally you're still maintaining. So we're working on a little bit of a revision around that as well. If we have an opportunity, we'll talk about some of the 2020 metrics. And actually, we just presented the risk coding, so we'll see what we're going to talk about around the risk. I know the risk scoring has been a big topic, and we're working on it in many different groups. If there is a topic that any of you are interested in, I certainly would ask you to send that forward to us, or any questions you have of this group that might be helpful. I would love to hear from any of you that say, you know, we could use some information about a specific topic. Obviously, we have a plethora of resources in our region and so many subject matter experts on a variety of topics. So if there is something that you think would really help, please get that to us. Next slide. This is just a reminder of some of the resources that are out there. Obviously, the AHI website, and we do have the practice transformation area that does post all of the recordings from these videos, so you can go back and review them yourselves. The COVID newsletter is still coming out on Monday afternoons. Not as much information, but with the potential of things gearing up and you know, things becoming a little bit more intense again, we're going to continue to provide the information we do get on a weekly basis to everyone. And then the AHI Informer comes out every other Thursday. There's always a lot of information about local organizations and any of our partners that are working on things. So you should see that in your mailboxes as well. As well, the ADK ACO website has been updated. I provide that link here for you. They've really done some nice things with it. I think there's a lot of information on there that's extremely valuable. And the ADK ACO monthly newsletter is also another resource for anyone that has you know, questions or things. I think that submitting information or asking questions is certainly a great way to get some of these topics into the newsletters. Again, you can submit any kind of information that you come across that you think of value, and we will certainly consider putting it in one of the newsletters as well. We currently do continue to post and share stuff on social media so that it gets out to many partners. Next slide. I guess that is it for today. Is there anything anybody has questions about any topic?
Luann, I was just going to ask if after the call that I might send out health home contact information to the group, just because I know that a lot of folks on the call are very familiar with health home, but I think, you know, in the spirit of the health home taking care of patients after they leave primary care or a clinical setting, and really supporting primary care usage, preventative care. I'd like to just send out the health home information if anybody on the call is interested in learning more about how to refer to health home, or what is it, if you'd like us to kind of give you a little more detail on who's appropriate for health home, we would be certainly happy to reach out, and I'd just like to make sure you have our info.
Absolutely, Anne. Thank you. That's a great idea. Okay. I will be happy, and I'm sure you're ecstatic to get 15 minutes back on your day. I hope everyone remains well. If there are any items that come up after, by all means, just email us and we'll try to get it into some sort of a generic email back to everyone if appropriate. And if you need any assistance at all with getting your submissions in for PCMH, do not hesitate to reach out. We're here to help. Thank you, everyone, and have a very safe holiday, and we'll talk to you in December.
You.
Thank you.
Thanks, Luann.